Hello, everybody. If you don't already know me, my name is Alex Theodore, and you might have seen me on Facebook for questions about the bariatric surgery evaluations because my inbox has been blowing up with this new possibility of either side income or maybe a completely new niche. So as opposed to trying to answer everybody's questions all at once, I'm hoping that this video is going to help shed some light on some things. And so Ashlyn, the course creator, was so graciously to kind of spare some time today to go through some of those frequently asked questions that I've been receiving so you get it straight from the horse's mouth. And I'd be happy to share some of my experience as well. Don't worry, I'm not trying to gatekeep anything, but I did want to give you guys the opportunity to kind of hear straight from her what's working, what's not, and so you can make a better decision on if this course is best for you. Ashlyn, thank you so much for spending some time with me today.
Thank you so much for having me. I'm so excited to know that this has been bringing a lot of questions, which it often brings a lot of questions for me too, because it's not a niche that it has a lot of people in it. So it makes sense that people have a lot of questions about it.
And I think it's just because it is not an obvious specialty, but at the same time, once you know it's a specialty, it's like, oh, well, why haven't I thought of it before? Like, it's not something that we hear about in school, like EMDR, CBT kind of thing. Like, this is its own different world, but still uses a lot of the same tactics. So would you mind talking a little bit about like how you got into this niche and maybe what made you decide to create a course in general?
Yeah, so like many things in therapy, this niche is me. So I am a 12-year post-bariatric patient who had a somewhat negative experience when I had my psychological evaluation for my getting ready to have bariatric surgery. And so I, for a long time, didn't want to necessarily, it's a little close to home, so I didn't get into it for quite a while. But eventually, as I saw that there weren't a lot of providers in the area, and there weren't a lot of providers who had lived experience, though not necessary, though most people in the mental health side of this aren't necessarily lived experience, and that's okay. But for me, I wanted to kind of be able to help other clients have a better experience. And then what I figured out is there's no real training on this, especially like nuts and bolts. Like, what does the letter need to look like? What does the template look like? How would you do marketing? So there's a little bit of information maybe on the education surrounding bariatrics, but not necessarily on how to do the actual evaluation. And so I created that several years ago and have been doing that ever since.
And it really is a very comprehensive course. I mean, so for reference, I purchased your course and took it a couple months ago. So it's still a relatively new niche for me. But what I loved about it, how it really goes into all aspects, not just what the evaluation is, but like you said, the marketing, like the highs and the low seasons, the billing aspects. And so like it truly is a comprehensive course where I felt ready to get up and go once it was done.
And that was my hope.
Yeah, no, and I think you achieved it. Now, I mean, everybody has different experiences. I came from a very like heavy medical background, so a lot of the things sounded familiar to me, but just in a different person. But that being said, I mean, what licenses are able to do this? Because I get that pretty frequently. Like, okay, you're an LCSW, great. Like, can I, as an LPC or a marriage and family therapist, do this too?
Yeah, so the American Society of Metabolic and Bariatric Surgery, so the ASMBS, which is our governing body, they recommend that it is someone with a terminal license. So we are at the end of the possible license. So we don't necessarily want associate level or registered interns, is what we call them in Florida, or students. So they recommend that you are a fully licensed, terminal licensed mental health provider. So you could be any of the master level licenses. So LMHCs, LMFTs, LPCs, LCSWs, all of those are appropriate as long as we can diagnose and evaluate. And so in most states, there is one state, I think it's Alabama, where social workers technically aren't allowed to give diagnoses, but they get around that by doing, they call it something. And so we did get clarification from ASMBS that they are allowed to do that. Their state just has some really interesting language around diagnosis. I think it's called like a tentative diagnosis. Very strange for Alabama, but I did get clarification because I kind of posed that to them as well. And then also psychologists, ARNPs, NPs, psychiatrists, MDs, they are all allowed to do these evaluations as well. But in the mental health world, as long as you are terminally licensed, you are allowed to complete these evaluations.
Gotcha. So if you're putting a mental health diagnosis, usually with some type of CPT code, if you're used to private practice billing, you're probably in the clear for the
Yes,
most part.
yes,
Sounds good.
yes.
Speaking of billing, right? Is this something that's covered by insurance, or is this strictly a private pay niche?
So this is an interesting question. So the majority of people will do these self-pay. And so, and I go over the scripting of this in
Hmm.
the training, exactly how we explain to clients why this would be self-pay, even if you accept insurance, because these evaluations are likely going to find that there is no mental health concerns, and therefore we don't have a diagnosis, which means we don't have a billable diagnosis for the evaluation. So some people do these self-pay. The majority of people do these self-pay. If you would like to use insurance, it's just your comfort level, or you find accessibility, or you want to work on a higher volume, you may choose to use insurance. There is no specialty code for this. So it's just going to be your 90791, your traditional intake. Most of the clients would qualify for an adjustment disorder because something has changed within the last 6 months where they are now needing to consider bariatric surgery. So there's usually a significant change in function or medical, or even psychosocial. So maybe their mobility has changed, their medical situation has changed. They've moved over from pre-diabetic to diabetic, and now they're trying to figure out the best treatment for them. And we did used to have FO631, which is mood disorder due to known physiological condition. I still use that quite a bit. So obesity would be the known physiological condition. There are a few insurances that don't specifically like that code for whatever reason. But to me, that is one that really fits everyone, because nobody's coming to me that isn't experiencing some kind of symptom of a mood disorder, usually depression or anxiety, surrounding their change in medical condition, where now they're considering this surgery. So that's an accurate one. The Florida Medicaid, for whatever reason, we do have a specialty code for these in-depth. We call them an in-depth evaluation. So there is actually a separation for these in the Florida Medicaid handbook. So there may be a specialized assessment code in your Medicaid handbook in different states. It's pretty rare for someone to take Medicaid, let alone do these assessments, though that's me. So I think that, again, the majority of the people that I'm therapists that I'm working with rather, are coaching. They're going into self-pay, and the majority, like even in my area, are going to be self-pay. If you do use insurance, we are allowed to charge documentation fees. So just like FMLA or long-term disability, you are allowed to charge a fee to complete paperwork. And so I do about a $50 letter fee. But I've coached clients that have they're more up in the 100 or 75. There's a little more. And usually what we do for that is we say it takes about a half an hour worth of my time to fill out the paperwork. And so if my hour is a $200 hour, then that 30 minutes. So that's how we kind of backtrack the justification. And most of the time clients are very understanding of that. And especially once you explain like where that, you didn't just, that's not a random number. It's, I normally charge $200 an hour. It takes me about 30 minutes. So that's about $100 worth of my time. And they're like, oh, okay, that certainly makes sense. So you can go either way, especially if you're in a state with pretty high insurance payouts. It makes sense if you want to continue insurance. But again, if you don't, or you're trying to get out of that, maybe you're doing more things outside of insurance and you want to add that, that's certainly doable as well.
Yeah, because that's where I get a lot of questions from people is like, can this be a completely private pay thing? Because maybe they're planning on kind of going out of network, or maybe they already have a full-time job and want to do something side gig and don't want to deal with insurance. So the second most popular question I get then is, it's like, well, how much do you charge?
Yes, and this one is so hard to, and it's funny.
I
And I will say in the training, I say one thing, and some of my opinion on this has changed. So in the training, I will say like call around, figure out what your area tolerance is for this. But I have to be honest, I think a lot of us our mindset around this is really shifted. You got to charge what is worth your time. And it may be helpful so you don't undercharge to see what other people are charging. So I'm working with a coaching client right now. She's out in the Denver area. Like her area tolerance is far higher than mine is here in Orlando. So when she looked around, really, she needed to be in the 400s versus where I am, which is in the 200s. because in her area, what she figured out is if she doesn't charge enough, then people may feel that she is not qualified or she isn't, there's something different or like in a negative way. And in her area, it's a little more affluent. So the tolerance there is a bit higher. So you probably need to do a little research into like what other people are charging, not necessarily to base yours completely off. I have someone in my directory who charges $1,000 for their evaluations. They do a full psych, neuropsych. So you don't necessarily need to do that, but I would say I certainly wouldn't want you to charge 150 if the going rate is 250. And people are used to paying that. Now it may be a marketing thing where you're a little under the market and that's fine. But I want you to make that as a conscious decision with information that you have. So again, that network or that area tolerance, as well as like what you're willing to charge. So some of my coaching clients come to me and they say, hey, I want to work on volume. I want to do this full time. And so they may make a different decision than the client that or the therapist that wants to maybe do 3 to 5 of these a week. And so we can charge a little more because they're okay if 10 people come in, if only 3 to 5 say okay. So I think that that's something to think about as well.
Yeah, no, it absolutely is. And that's, I mean, for reference for people watching, I'm here in New Jersey, and at this point, I have one insurance panel that I'm insured with. This way, it gives me a little bit of a safety net. Most people are out of network, and the rate that I'm charging, that I looked off of based on the research that I found, was $550 for a complete evaluation. So that is 1, possibly 2 meetings if need be, as well as the report writing and any kind of consultation, coordination of care with the doctors outside of it. Now, if you're doing insurance, you might be billing for each session individually, the report writing, and then maybe consultations if they're extended ones. Usually if it's 15 minutes or less, we just kind of throw it in as a freebie. But that might give you an idea to ballpark where you are, at least where you could be looking at.
Right.
How long does it take to do the eval? I mean, I know you said the writing part is about a half hour of your time, but can you give us an idea of like from start to finish with the client, like what you're looking at?
So you can do this in one of 2 ways. So some people like to do one and done. So again, if you're more on a volume basis, this is what you want to do full time and you're just kind of stacking them. Usually a one and done, but also sometimes, especially when I have coaching clients who are trying to separate out a little bit, maybe they're going to go through the insurance, they'll do it as 2 appointments. So they'll do the biopsychosocial in the first, and then they'll do the education series and the bariatric specific questions in the second appointment. And so again, that gives them, especially if the payout is a little higher, that may be closer to their self-pay rate or the rate that they want to get for the entire assessment. So I've gotten it where I've templated the letter into my EMR, and I've actually gotten it down to about an hour in session and about 15 minutes doing the paperwork. Back when I was using more of that full letter, where is it, a Word document, I was having to double check to make sure all the names were, everything was great. It was about an hour and a half. Part of the reason that I've been able, I've done probably 1,000 of these. Like,
I was gonna say, you've been doing this for a while.
I've been doing this for, I should probably preface this, but I've been doing this for a really long time. And I've probably literally done over 1,000 at this point and overseen probably at least 1,000 more. So that is one thing. But I think in the beginning, I would always give myself about 90 minutes with the clients. And then as I've changed out my paperwork, and this is one of the things too, in the training, you get all the paperwork, and I specifically make it so that you're asking the client every question that you need the answer to before they even come. And it's really important that they complete that paperwork prior to making the appointment. So that way they are taking the time to answer all of those questions. And there's quite a bit of, questions to be answered. But that way my paperwork and their paperwork follow each other. So every question that they ask, the answer on my side follows it. And I was very, I did that on purpose so that I could, and it makes it faster. So I don't want to have to move around and where's this question and where's that question. It follows it. So a lot of what we're doing, and sometimes too, getting faster, is also figuring out how much to ask and how much not to ask. So these assessments, we have to think of a little differently. They are not therapy, so I don't need the depth of answer that I do in a therapy session. I need the depth of the answer to answer the question on the assessment. And so sometimes for non-psychologists, this is a little more challenging because we weren't really taught the difference in...
We want the dirt. We want it all. usually.
Yeah. We want like, oh, your child,
Yeah.
tell me all the details of your child, right?
Yeah.
Where really I'm just looking overarching. Did you have a safe childhood? Generally, your needs were met versus like, the nitty gritty. So
Mhm.
in the beginning, I probably got way too much information as I was trying to kind of get into the groove of these. And also, some of these too are just getting used to helping the client also answer in the way that you need them to. So I don't necessarily ask every question again. I definitely don't ask every question again. I'm mainly asking clarifying questions. So I'm going
Mhm.
through, and I also, it's interesting because I don't do a ton of this in normal therapy, but for these evals, I run concurrent with my documentation. So I have their answers up and my documentation up, and I'm doing it at the same time that I'm talking to them. And I have a touch screen, which makes things really easy because I'm
Oh
literally
yeah.
like, and all of the forms that I've inputted into my system that I give you in the training are check boxes. And there's only a few that I actually need to type things in. So that makes that a lot faster and more efficient, but I still want to have very thorough and really good evaluations. I just want the documentation part on my end to be faster and more efficient.
Yeah.
Because the majority of the time, and we'll get into why this is probably another question, but I want to spend the majority of my time on education versus the like getting all the details of their life, because at the end of the day, that doesn't necessarily impact outcomes. Their knowledge about when to come back and what is expected of them is actually dictates outcomes. And we found that kind of over and over again in research. So,
Yeah.
yeah.
Yeah. And I mean, that goes kind of into the next question, which is about liability. I mean, the
Yes.
role of the evaluator in this case is not to gatekeep, right? It's not to
Correct.
stamp a yes or no. It's to
Correct.
help them optimize their recovery. So there are specific questions you need to ask and to listen for to make sure that there aren't red flags that are going to hinder their kind of recovery process. And then if the red flag comes up, helping them figure out how to navigate around it. It's not saying, oh, red flag, fail. It's
Yeah.
red flag, okay, let's talk about it.
This is probably the biggest misnomer about these evaluations and the liability of these evaluations. So we are not saying that anyone is appropriate or unappropriate for surgery itself. That is a medical question for medical providers to answer. So we are not saying this client is a good candidate for surgery. So sometimes clients or therapists will ask me, sorry, I have my clients in coaching or
Okay.
therapists.
Yeah.
I keep saying clients. They'll say, well, what if the client dies on the table? Are they going to come back?
That's a scary thing. Yeah. Yeah.
It is, especially if you watch 600-pound live, like your
Yeah.
exposure to bariatric surgery is probably not a lot. So you probably are not aware that the majority of the patients that are having bariatric surgery are not who's on 600-pound life. They're usually around 100 pounds overweight with some medical complications, but not to the impact of like what that show would indicate. So the answer to that is that we never said that they were good for surgery. Anyways, we were just saying they have the ability to give informed consent. So our job is to ensure that they don't have dementia, significant neurological conditions that impact their ability to make decisions for themselves. And that if they have maybe something that does impact neurologically, maybe autism or a neurodevelopment disorder, that they have support, and those people are going to be able to help them to make those decisions. So, and again, I go into like some really minute details in the training, like if you see this, this is what you ask. But we're not suggesting that anyone is good or bad for surgery. We're not saying you are the perfect candidate or you need to do all these things. In general, we may give recommendations. We may say, hey, it sounds like you've got a little bit of something mental health brewing. This is how you get into services, or this is what you may see that you may want to seek out services. It's not very often that we're requiring, unless it's life-threatening substance abuse, eating disorders, severe mental health. And even with severe mental health, which does come up when people are bedbound or not able to make decisions for themselves, we still may have instances where that may be true, but delaying surgery may actually cause their own death. And so those are situations, and again, I'll get into the training, that we would reach out, like we would note what we see, but we'd reach out to the surgeon to say, hey, if I delay this client, is there a potential they could die? And if the answer is yes, then there's no point in delaying them because they won't be able, they could die. So those cases, we're going to work a little, they're very rare. And in my entire career, I've had two. Where the client probably was suicidal and pretty significantly mental health was impaired, but it was because their current situation, because of their weight, they were bedbound. And so what kind of life could they lead? And their fear is if they didn't get the surgery, in both cases, their health was so declined that they could die. And their surgeon had made them aware of that. That would probably make me pretty, that my life has gotten to a point of unmanageability on my own. So in those cases, but the liability on these are relatively low. There is a whole team of people that have to also sign off. There's nutritionists, there's the cardiologist, there's all sorts of people. So we, this is America, you could be sued at any time for any reason, and could you potentially be sued if a client died? Yes. I've never been sued for any reason, good, bad, or indifferent. I either, delaying or not delaying, or a client passing away, which we have had. Because that is also the outcome of obesity. Sometimes the conditions do deteriorate to the point where it can cost someone their life. So that is a part of this niche, but it is very rare. And like I said, I've never been sued, even though I've been in some situations. More likely than anything, the main person in the suit is going to be the surgeon itself or the hospital system, because that's where the money is. But I don't really view these. I understand why people do have concerns surrounding liability, but I don't view these as a high liability, because there's a large team of people that have to make decisions after. So I really think of this too is giving the surgeon heads up so that they can make good decisions. So we had a client recently that told us that they were smoking, but they had told the surgeon they weren't smoking. So we're going to disclose. Yeah, so we're going to disclose that. So I can't stop them from moving forward for smoking, but I notated that they were smoking, and I actually personally reached out to the surgeon. It is one that I know well, and actually I think would have been very understanding of the situation and might have changed how she was going to approach the situation, knowing that the client was in fear that she would find out and be very upset with her. And so the surgeon said, here's what we're going to do. She's like, I'll run the nicotine test. So there's a test that they normally do for nicotine. She's like, I'll go ahead and have them fail out. And then the client and I will sit down and have a discussion about how we're going to move forward. I'm not going to discharge them. I'm not going to leave them hanging. I have a plan for what I do in these situations. I wish that she had came forward to me and let me know so I could help her versus going this route. But, it's, again, the surgeon needs to make those decisions. It's not for us, but I will give that information to the surgeon so the surgeon can have those conversations and, hey, and we're going to educate them, of course, of why we don't recommend smoking, as it can lead to ulcers and cause pretty serious medical complications. And that's why the surgeon is so concerned about you smoking. It's not a judgment. It's not that they think you are a bad person for smoking or anything like that. It's a medical issue. So I think too, part of our job in the liability factor too, the kind of liability shares, is we're sharing information with the surgeon for the surgeon to make the decision, not necessarily for us to.
Yeah. And I mean, you've said a couple points that I really want to highlight is with the education piece, like the smoking thing came up in your session, but not in the surgeon session. And your course does a really beautiful job of giving you the psychoeducational material. So like, first question that came up in my mind was like, well, why does smoking matter? Like in mental health, like, yeah, we know we shouldn't smoke, but like there are some serious complications that could happen if you smoke post-surgery. But you outlined that beautifully. So even if you know nothing about this population, I mean, granted, you still have to do your due diligence and research. I wouldn't just take this course and be done with it, but it gives you a strong foundation so you understand and then can follow up and learn more about why. And that's really important. And another thing that I wanted to kind of throw out for people who are thinking about the course in this population is you're working very closely with these surgeons. Now, some people, and correct me if I'm wrong, it might just be a port out and you never talk to them again, but others you're talking to like this situation. So it's a little different than our standard therapy where everything is kind of behind closed doors and you talk to people on occasion. There's much more open dialogue and making sure that informed consent is very clear up front.
Yeah. So you always want to have that signed before you ever talk to them. Because again, like other forms of assessment, immigration assessments, DCF, that they may disclose something to you that you need to disclose to the surgeon, and then they may be upset with you because you disclosed it. But it's like, that is my job. The entire point of this is that everything gets disclosed. Usually what I do too, this is a good, if the client says that I lied about something, this has come up twice. So I had a client that smoked. I had a provider who was really strict. You can't smoke for a year. You said you smoked. And she said, no, it was a misunderstanding. So the client filled out that form and said, I currently smoke. I have smoked. So they gave me all that information. So I don't normally disclose the client facing paperwork, what they fill out. But on the bottom of that form, it says that if the information is not detested, if it is contested, I will disclose this information if need be. And so that client had said, I'd lied. The provider reached out to me and said, hey, the client said that she didn't tell you that. And I said, oh, that's interesting. Let me look at the paperwork. I said, okay, I'm going to send you the paperwork that she signed and filled out. And you can do with that as you please. But sometimes that does come up, and a little bit of like backtracking. Oh, I probably shouldn't have told you that. And it's like, okay, well, we need to disclose it. But again, in the training, I go over to like, how do we word this so that they best understand this is in their best interest? There's a reason that we do, like the smoking in particular, that one can get kind of contested. If you smoke post-surgery, you can have ulcers. If you have ulcers, they can bleed. Bariatrics lends itself to anemia already. If you have a bleeding ulcer, that can irritate anemia or make anemia worse. If you have untreated anemia and you need a blood transfusion and you don't get one, you could die. So that is really why, in particular, with smoking, that's such an important one to educate around, because though there are types of surgery that so the one surgeon that had talked to me, she said, well, you know what we're probably going to do is I'm going to offer her a sleeve instead of bypass, because sleeve has less likelihood for ulcers. And if she's going to smoke again in the future, I can at least help her protect herself a little bit if she goes back. So her rule is 1 year. And again, this is surgeon to surgeon. This is not a blanket statement. Her rule is 1 year, no smoking. And then you have your choice of all types of bariatric surgery. But in her world, that if you have smoked within the last year, she wants you only to do gastric sleeve. So different, and again, we aren't making those decisions. We're letting the surgeon, but that information allows them. I will say too, you may also in this niche not be talking directly to the surgeon. You may be talking to their patient advocate, their nurse, their front desk. I have one office, it's his wife. She kind of runs everything that's not surgery. So like her and I are the ones talking. It's a very small office. Or I have other ones, they have hospital systems that have patient advocate. So my communication is through the patient advocate. If I need to flag something for the surgeon, I have to flag it with the patient advocate first. And then I can, do our next step. And then the advocate will report to the surgeon. The surgeon will either report back to them or report directly to me if they want. So each office may have it set up a little differently, but this is definitely something where we have a bit more communication with the referral source. But, and I know you're going to ask me this, the surgeon is the referral source. So we want to make sure that we are communicating openly with them.
So that's a big piece of this, is the marketing. And it's a question I get asked frequently, like, can I just write a Psychology Today profile, throw it up, and be done with it? What are your thoughts?
Okay, so the biggest thing with this, which I love, is that your referral source is not the general public, because that is like a needle in a haystack. Your referral source is the surgeons. They are the holder of all the appropriate clients. So yes, for some legitimacy, having a website, having Psychology Today, making sure you talk about bariatrics, because there are people who going to do due diligence and Google you and see if they can see if you know anything about bariatrics. But in general, because so few people do these evaluations, the surgeon will send them directly to you. And so your marketing, and again, we talk about this in the training, is you probably want to go out to the surgeons, introduce yourself, send a letter. I like to show up with some food, tends to go a little better. We even had, I was talking to a coaching client, why don't we throw a $5 gift card for Starbucks in there, and then we can have virtual coffee. You bought them coffee. They may be a little more likely to call you back because you added a $5 gift card. There may be a little more pull to say like, oh, I'd like to talk to you. Now, we aren't buying referrals. We never, ever give money for referrals. We never give gifts based off referrals. But sometimes that may start the conversation. Or when I bring food, I put a little card on the food. So that way, every time someone opens, they're like, who brought us food? Bariatric surgeons don't get a lot of visitors. So every time they open it, they'll see my card. Oh, Ashlyn came by, dropped off some information. Oh, what does she do? Oh, she does our evals. Oh, okay. Oh, that's good. You know, so it's I
Mhm.
don't feel there's any
It's an
yeah,
icebreaker. It's
yeah,
an icebreaker. I mean, I have an appointment tomorrow with somebody that I actually just got off the phone with before this call, and we have like a little breakfast date, so to speak, where I'm gonna go. We're gonna kind of meet face to face formally for the first time. I'm gonna bring something to eat, something for her to share with me, and we're just gonna chat. Again, it's not meant to bribe her in any
right,
way. It's just so there's something to do with her hands, so it's not this awkwardness just kind of sitting next
right.
to each other. So
And
that's
sometimes
where I think
too,
of it as.
I'll do a lunch and learn. So I'll ask them if there's a topic. So suicide assessment, how to know when to refer for like post-op, how to go about finding therapists that know anything about bariatrics. So I'll do a little lunch and learn, and I will bring in lunch. I'll ask them. Sometimes I'll just say, you know, where does everyone want lunch? They're like PF Chang's. I'm like, all right, tell me what you want. I just ordered off the lunch menu. I go pick it up, and then I do my education series. And again, um, that's not a return for referrals or anything. It's just education, and we do that in quite a few of the
It's a marketing expense, is
yeah,
what it is.
yeah,
It's a marketing expense. Two questions kind of go next with this, but I'm going to combine them together. Is how long does it take to kind of get clients after the training, and like what's the return on investment? I know it might be really hard to answer specifically because everyone's so
yeah.
different.
So like for your price point, it would take one eval.
Yeah.
So that's
Yep.
good. It kind of depends on what you're charging, but um, I always tell people too, you just need one surgeon. If
Yep.
you just have one, so I have 12, but I also have a group practice where this is almost all what we do. We have availability for like 40 spots a week, you know, like it's
So
a
you can
full
do
time.
this full time if someone
Yes.
wanted to. It doesn't have to
Yeah.
just be a side gig. Like you can
Correct.
make this your home.
Yes, you
Wow.
could, especially if you have some busy surgeons. So,
Mhm.
but especially if you're in an office that maybe has multiple people that they refer to. But if you have one good surgeon, you can get this up and running literally overnight, because your
Mhm.
surgeon will be the one who literally the next day will have people, new clients coming in. And you may want to ask them too when you're going in, like if they have an intake day. So I know I had the first surgeon I ever worked with, his intake days were Mondays and Thursdays. And so I knew on Mondays and Thursdays, that's when my evals would come in. So I always had space to make my phone calls and get everybody situated on that same, like while anticipation was high, they met with the surgeon, they're really excited. I'm one of their next steps. So I knew when those referrals came out. A lot of surgeons don't necessarily have an intake day, or like they don't set themselves up that way. That's just the way he did it. But then I could kind of, but again, like knowing that information, being able to kind of meet clients that way. Occasionally, sometimes the surgeon, again, way back in the day, I used to be in the office on intake day.
Mhm.
So they would just meet me, and he had intakes, I think it was like Thursday afternoons or something, and I would just hang out. They would meet me to make their next appointment. That was just something
Awesome.
he liked to do.
That's nice. Yeah.
Yeah, yeah. And I was really close by. So I was literally around the corner. So I would do admin work in a back office, and then
Mm.
pop in and get everyone scheduled as a part of their, again, this is a while ago before I was as busy as I am now. But that worked really well for me, because that way, one, I had dedicated time to get some admin work done.
Yeah.
And two, we just made those appointments all at the same time. So that way, it was easy for them to follow through. But you can get creative. Again, a lot of the surgeons, they're trying to save money. They may used to have an internal evaluator. They no longer do. So they're looking for those resources. They may need, we talk a lot about yesing their no's. Can you get them in faster? Can you turn them around faster? Is your price different? So whatever the issue is that they may be having with their current evaluator, how can you work around that? So especially during the
Mhm.
busy season, sometimes people will get, 6 weeks backed up on appointments or turnaround. And if you can get them in within a week and turn around their paperwork within 48 hours or by the following Monday, whatever you set up for yourself, that may be a marketing piece too, and how you kind of yes their no's. And those are some of those things you can think about before you go in to meet them. So that way you can kind of answer some of those questions more confidently.
Now, I know you're talking a lot about the practice being busy, which is fantastic. Do you have any thoughts on if someone just wants to do this as a side gig? Like, listen, like if I can get 4 or 5 extra sessions a month to kind of pay off a car payment, that would be great in my book. Like, is that even possible, or are they setting themselves up for failure because it's just too
Yeah,
much
no,
work?
no, no. You definitely, if you're wanting less, again,
Mhm.
I would price yourself that way. But yeah, I might just find one office that's going to provide you referrals. And if you feel like you're getting overwhelmed, you may want to find someone else that you can also refer, or to talk to the surgeon about specifically what type of ones you want. So I have one coaching client who really only likes doing evals on people who want ongoing therapy. And so
Mhm.
her and the surgeon kind of have an understanding that someone who's interested, who's really like looking for that like long-term care support, those are the referrals for her, not the one and done. It's kind of the opposite
Mhm.
of some people. So,
Yeah.
but she has that kind of communication with the patient advocate and surgeon. And so those are the ones she really likes to take on because she likes having long lasting relationships with clients versus a one and done model, which is totally fine.
Which is
So,
funny because I prefer the one and done. Like
right,
I came
most
where I was
people.
feeling burnt out from therapy. I almost thought about leaving completely. And then I found your niche and I was like, oh, this is an opportunity to still keep my clinical skills sharp, but not have to be in therapy for 3 years with the same person.
Yep. And actually, that's part of how the training came to be as well. During the pandemic, I had a friend of mine who had reached out. She's like, I'm out. Like, I can't
Yeah.
do this anymore. I don't know what. She's like, I'm just gonna go travel the world. And I said, well, what if you just did a couple evals like one day a week? Because she was gonna be in South America. I said, you 250 for a week. Do them one day where you have stable internet. It's $1,000 a week for you to travel around, and then when you come back, never do one again.
Great. Yeah.
Get out, get unburnt out, and please come back to the field, because she actually had a different niche that was like really needed. And I'm like, no, we still need you in the field. You just need a break, and this is a way you can still make money while on that break. And again, maybe you never do it again, or maybe you find it's interesting for her. She found this population she really loved, and so she's like, no, I'm gonna keep doing it. But it was a way for her to like step out, almost have a sabbatical, but still have
Yeah.
a step in and make some money.
So if for my peeps who are maybe going on maternity leave and want to spend time at home with baby and but want to do something clinical but not full practice, that's is an option for
Yes,
somebody who
especially
maybe has
because
a
our
yeah.
clients are really expecting daytime hours on this. Most clients are not expecting you to do nights and weekends. They are expecting you're
Mhm.
going to be like every other medical provider they're calling. So if you only have during the day when the kids are at school, or you have, your partner or someone who's helping you comes at a certain time, you can really make these times work. But also on the flip side, it's a marketing. If you are nights and weekends, let's say you're a stay-at-home
Mhm.
mom and your partner comes
Yep.
home, and you could offer these nights and weekends, and we have some weekend hours and nights, and people are always like, oh, I can come in on a Saturday. Like, I have so many appointments already. That would be great. So it's
Mhm.
interesting because the expectation is not nights and weekends, but they're very appreciative and can be a marketing aspect for nights and weekends.
So you could really make this your own depending on what your lifestyle is, which is what I'm all about. Is a life first and then a business that works around it versus the
Yeah.
other way around.
Yeah.
I want to be respectful because we're getting close to, I believe you have a session after this, so I don't want to
You're,
hold you super long.
you're okay.
Or do you have any other final thoughts before we wrap up? And then I'm also going to talk about before we close a gift that you brought for everybody today.
Yes. Yes. So I would say the only therapists that are maybe not a good fit for this niche is if you have a true bias towards those that are in larger bodies. And so you probably do need to have a conversation with yourself. If you truly believe that the only reason that people are in larger bodies is because they lack willpower, or they just need to eat less and exercise more, this may not be the group for you. The underlying cause of obesity is not lack of willpower. There's a metabolic condition. I go over this in the training as well to better help people maybe who've never been in larger bodies understand. There's a metabolic condition that causes most obesity, and it actually has to do with your pancreas and your insulin. And it's not talked about a lot. It's why all the fancy GLP-1 medications are seem like a miracle drug, because they're
Mhm.
actually treating the underlying cause of obesity. So I would say other than that, this is really a good niche. It doesn't matter what you yourself look like. The clients themselves tend to be very understanding. They're not looking to you to be the perfect example of bariatrics. They don't expect you to have lived experience. If you do, it's great. If you don't, their bariatric surgeon likely has not had bariatric surgery. They know a lot about it. That isn't it. But I really recommend that giving this a shot. The clients as a whole are highly motivated. They need you to move forward. So they're highly motivated to see you, to accommodate, to do what they need to do to get this completed. They are a group that probably has a little more people pleasing and perfectionistic behavior, which is kind of helpful for us. Sometimes we have to kind of cut through some of that, but I do think that this is a really wonderful niche. It literally is my niche. And I'm also working on a training for intensives that are not as intense. So if you're someone who is maybe thinking about, oh, I could do pre-op intensives, I'm working on a training for that. Especially, it's more of a psychoeducational intensive versus like a trauma or a very intense intensive. And so that may be also something, especially if you're trying to kind of get out of that hour to hour therapy model, that's something else, but same population. Again, you already have your referral sort, you're doing all the stuff you already have to do, and that can just be something else that you add. But it is a wonderful niche to work with and very much needed. There aren't a ton of us. It's pretty evident when people call me and they're like, you're the 30th therapist I've called and no one knows how to do these evals, or I've had 3 done and they're all incorrect.
Wow, that's a nightmare.
That definitely is there.
Yeah. So I will link below this video the information to the course itself. I'll also link Ashlyn's contact information. So if you had questions about the course, but also her coaching services, because there are a lot of different ways that you can incorporate this, you're always welcome to reach out to her. You're welcome to reach out to me. I'll link mine as well about my experience with this. And Ashlyn was very generous enough to give us a gift. So there's a $25 discount for anyone who uses the coupon code STRESSLESS. I will write it down below. That is, again, a gift for her to us to give this course a shot and to test it. And I can say from personal experience, I was blown away with the amount of information in there. And this is my new niche. Thank you, Ashlyn, so much for coming. And I can't wait to hear what people say when they watch this video live.
Yes. And also, if they want to sign up for the newsletter, I do send out a weekly newsletter, and that also includes I do a free case consultation once a month. We do case consultation, though lately it's been mostly business consultation, which is totally fine. That's free. It's the second Friday of every month at noon Eastern. So that will literally be tomorrow when we recorded this. So that is something you can come catch me next month. But in that newsletter, I always let you know it's valuable information. So like right now we have a little bit of a slow season. So last month and this month, we've been like, what do you do during the slow season to get ready for the busy season, which will start here shortly. And so I also give you valuable information in the newsletter, but as well as any kind of trainings that I have coming up or events, anything else that I may be working on, how to get into coaching or a one-time case consultation. I do that too. Sometimes people just want to do a 1 hour about their business or 1 hour about cases or marketing. I'm more than happy to do that as well. And that's all on my website. You can literally do it all from my website. You don't even have to contact me per se and go back and forth. My scheduling, you pay for it, you schedule it, everything is through the website.
I mean, the fact that you get a course and a consultation community all in one purchase is fantastic. Because when I bought it, I knew I was getting a course. I was not expecting the consultation, which was a huge bonus surprise. And I'm glad you brought it up. I didn't want to call it out in case I was supposed to be like a surprise at the end of it. But yeah, no, it really is. It's worth it just for the consultation, because supervision, I mean, that's easily $100 a week right there.
Yeah.
So I'm going to let you run because I know you have an eval. Thank you so much for spending time with me today and getting these questions answered. I know people are going to be thrilled to get kind of formal answers to these questions that have been buzzing up my inbox for the past 2 weeks.